Perfect. Well, Clifton, what do you say we get started as people are filing in? So thank you all very much for joining us. This is the most recent edition of the ACS Journal Club on this time dealing with complications of proximal humerus fractures. We're very lucky to be joined by people that we don't need to really introduce, but are known for their expertise in this really complex area of shoulder and elbow surgery. And I know it's going to be a really fun next hour that we have. Clifton, do you want to say a word before going to the sponsor?
Yeah, absolutely. So I'll be managing the Q&A session, the chat. So if you have any questions, please feel free to put that in the chat and we'll make sure to get that to the experts. But otherwise, let's have a good time. This will be fun.
Good evening, everyone, and welcome to the ASCS Foundation webinar series. I'm Scott Gunn, Vice President of Shoulder Marketing and Sales at Smith & Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Fantastic. Well, let's get started. So please, as Clifton said, please chime in if you have any questions. We're going to start out the evening with the intramedullary nailed systematic review. So complications following IM nailing of proximal fractures and humeral shaft fractures. This was a systematic review out of Duke with my co-moderator and friend, Dr. Clifton. So they basically using the Prisma guidelines look at 179 studies in 7,984 shoulders. So a tremendous amount that were included in this with an average age, as you imagine, around 55. So overall, they looked at it from a grouping standpoint, as well as breaking it out between proximal fractures and humeral shaft fractures, and looking at the role and the complications associated with IM nailing for both. So overall, when you combine both groups at a follow-up of 16 and a half months, the overall complication was 19%, and the revision rate was about 7%, or just below 7. Most common reasons were fracture-related complications, followed by hardware-related complications, and then soft tissue complications. And this is once again grouping the overall, the proximal humerus with the humeral shaft. When you looked at proximal humerus alone, so IM nailing for proximal humerus fractures, and this is all comers, so straight nails, trochanter nails, etc. They had a 24% complication rate, and there was a 9.4% revision rate. This is the worst with the 4-part fractures, so 53% for 4-part, 24% for 3-part, and 14% for 2-part. So clearly worse for the 4-part fractures. And then when you looked at just the humeral shaft cohort, it was a 21% complication, so similar to proximal humerus fractures. And the most common reason to have a complication in this was an open fracture. So it seems like these 4-part fractures and open fractures tend to have be worse actors, which is pretty obvious, I think, to most people. So really interesting study, very involved. I can't imagine those besides Clifton actually doing the work to do this. I can't imagine the amount of work that went into this. The assessing complications and revision associated with IM nailing. Overall, not that bad of a complication rate and relatively low revision rate. That being said, clearly there's some bad actors, 4-part fractures, open shaft fractures, etc. And really contributes to this emerging literature. I mean, IM nailing is catching steam. It's becoming more popular. I can personally say that I've started doing more and more of it, especially for proximal humerus. And I think it's something that'll be interesting to use this as a way to establish an algorithm going forward. So really, really well done study overall. So Hatz, I'm going to pick on you first, since I know you are an IM nailer. So why have we seen this emergence in IM nailing? Why is it within the last decade have we started paying attention to this, and why does this seem to be it seemed to be catching steam, at least in certain sects of the world?
Well, that's a great question, Eric, and thanks for inviting me to join this webinar. So I think it's It's a great study, first of all, Chris and your colleagues, congratulations. And the complications were assessed from 2003 to now, basically. And what the study showed, a little espresso, Eric? That's good. I need some of that. Basically, the older nails didn't have screws that interdigitated into the proximal part of the nail. So, I'm not going to say any names, but screws that depended on cancellous fixation of the bone, which is often really not very good, and also screws that are facing towards the head mostly. And I think what we're seeing now with more recent designs is there's more attention to fixing the tuberosities, locking the screws into the proximal segment, and having smaller nails that are designed to go through the rotator cuff muscle and not through the cuff insertion on the greater tuberosity. If you looked at the product guides for even 2003, 4, 5, they would show this parting of the Red Sea, just kind of split the cuff and put the nail right through the greater tuberosity, creating an irreparable cuff tear, basically, or big hole there at least. So I think those older nails from the first part of 2000s, not very good. More recent nails from most of the companies have instilled some of the same principles that I just discussed with varying degrees of proximal humeral spread. I think spread is really important, and I think that's how you decrease your complications. It makes two-part fractures a no-brainer, as you've probably seen in your practice. Very low complication rate, and from the more recent articles, very good results. 3 and 4 part fractures are trickier, and you can see the higher complication rate in 4-part fractures, which you see all across the board, whether it's plates, nails, any kind of fixation. They're just worse actors, and we probably have to be more careful about our selection. But overall, I think technology and technique have improved our outcomes with nailing, making it a really dependable treatment for proximal humerus fractures, fixable fractures.
That's great. Jenny, can you talk to us a little bit about these bad actors? So these 3 and 4 parts, they more and more studies suggest that when we plate them, we have issues. It seems like when we nail them, we have issues. Maybe we just do reverses on everybody. Maybe that's a solution. I'm not sure. But can you talk to me maybe if you do IM nails, like when do you ever consider it for this? And if you're not for a plate, how are you optimizing those more difficult fractures?
Yeah, I mean, so my bias is that I am a plater. So I think after Marius and I had a debate last year, I did my maybe first or second nail ever. I was convinced after listening to his talk. But yeah, no, so that's where my bias is. But I would certainly consider nailing 2-part fractures in, maybe someone who has more comorbidities where you don't want to do a big open approach for. Those would be ones I would be comfortable with. I think 3 to 4 parts, tuberosity control, in addition to, calcar support and stuff is very crucial. And I don't know how to achieve that with a nail. And so for me, the plates have been very reliable to be able to pass suture through the dedicated suture holes. It's an open approach for me, so I can bone graft, support the medial calcar and or lateral wall, which is in one of the other papers that we'll talk about later. But really, evaluating, is it fixable? And then certain questions I ask myself, can I obtain a reduction? Because that's probably the most important thing, regardless of what kind of implant you use. And then can you maintain it? And that's where all the different augmentation options come in. So if I could say yes to both of those questions, then I err towards fixing. My other bias is I tend to fix and preserve anatomy over reverses. But if any of those I can't achieve, or the patient has really poor bone quality, then I would default to a reverse.
Jenny,
Yeah.
teach me your secrets. Complication rates are over 35% with plating. You don't have any? I'd love to hear how you plate and why I can't do it, because I stink at it.
Yeah, I mean, I think there's certainly a selection bias for sure. But for me, even regardless of age, if the head segment is pretty big, and I don't actually have a number, it's maybe more than a centimeter and a half of actual head left. And then also the tuberosity. If it's a nice big tuberosity where I can actually capture it under the plate, then those I tend to fix. But I think, these proximal humeruses take me 6 hours. And so they take me a while. I critique my reduction. In addition to plates and bone graft, I'll use mini frag plates and stuff like that. I've also used plates inside the medullary canal as well. I think this is recorded, but yeah, so I do everything to kind of optimize it. I certainly get complications for sure, stiffness being one, but thus far, knock on wood, I haven't had any catastrophic failure of loss of reduction.
That's the difference.
Yeah.
I'd have to be medicated to operate for 6 hours. No
I
chance.
have to clarify what Jen said though. After our debate, she's an excellent debater, by the way, one of the best I've seen. She's awesome, but she's an excellent technician. And she showed me a 6 hour case, which was a whole shaft and proximal humerus. I think there's a dislocation involved, Jen. I mean, it was just virtuoso. I think that's your 6 hour surgery, Jen, but for more of a simple 3-4 part fracture with a plate, probably less than that, I would guess, right?
Yes. Yeah.
Yeah. So you're talking about all the way stem to stern. I just
Mhm.
and the X-rays she showed me were absolutely best I've seen.
Yeah, but I mean, I think there are plenty of papers out there now that have really focused on reduction, right? So obtaining a good reduction is probably the key to try and reduce the risk of the complications.
Yeah, no, that's great. So Eric, without question, what Janine brought up, the reduction, the calcar, the tuberosities, and as we know, the tuberosity is probably the most important aspect. But like, on conversely, when you look at those that have anatomic necks, they're really bad actors. They get AVN at really high rates, and it's really hard to sort of solve those. So talk to us, maybe how are you approaching some of these harder ones, the 3-4 parts, those without anatomic necks and the more calcar involved versus those that have calcar involved. Is there a role for IM nail for you? Is this a plate and graft situation? Is this a arthroplasty situation?
Yeah, I think I actually have a very similar approach to Jenny. I mean, I'm biased towards plates, but I will also, if I use a nail, it's the same patient she described. It's the sicker patient who I think I need to do something, so displaced 2-part, who I can be minimally invasive with, and who I feel I got to fix the fracture because of the level of displacement. I've not personally tried to fix tuberosity involvement with nails like Armand will do. So that's what I've limited it to. And I would agree with Jenny in terms of techniques. I think the amount of bone on the head is key. So you're talking about those anatomic neck fractures. I mean, I agree. If there's a level of bone where you can't get enough screw fixation in the humeral head, that's going to make me tip towards reverse. And then I think your medial calcar is very important, not just for comminution and bone loss, but also that medial soft tissue hinge. We know that from the literature. If that soft tissue hinge is intact, it gives you a reduction hinge that allows you to have the fracture be stable while you're placing your screws, placing your plate. If you lose that sort of soft tissue hinge and start to see that humeral head be unstable, then that's when you start thinking more about reverse. So if I get in to a case and I've got very little bone on the humeral head, I've got a disrupted medial soft tissue hinge, and you'll see those cases. The head's like very, very difficult to control. That's what's going to tip me to do reverse. So, but I have a question for Armand. So, is there a fracture you will not fix with a nail?
It's a great question. Loaded. Great question, though, Eric. A not fixable fracture, right? Heads in multiple pieces, tuberosities tatered, older patient. But if it's a fixable fracture, I think it usually very doable. I think the mistake is to try to percutaneously do all of them. And Ben Sears and I looked at our results and pushing the envelope with trying to do percutaneous on more 3-4 part fractures. And I think what Jen and you were both talking about is the key to the reduction, same in nailing, getting that reduced perfectly, and then using the nail properly. And the nails work differently with the proximal fixation, but using the screw directions to fix the tuberosities ideally adapted to the tuberosity displacement, i.e. if the LT is the displaced fragment, focusing on that, getting that perfect and getting the rest and then vice versa GT, which is the more common multi-part fracture that's fixable. So I think if it's fixable, Eric, and you're comfortable, you can do it with specialized techniques.
Can you just talk about cuff and shoulder sparing techniques? Because I think that's like the big concern that a lot of people have is shoulder pain, right? That's what the literature shows. What do you do? What are your thoughts?
Yeah, so straight small nails, not using a small, huge nail. And I'm more of a nailer for proximal fractures. For humeral shaft fractures, a different animal. I'm a little more prone to plate those fractures, even though I don't see a ton of those in my practice. But small straight nail, medial insertion point, anterior to the AC joint versus not inserting the nail lateral to the acromion. I think it's a big mistake. That's what was taught for a while. It's really anterior to the AC joint is the insertion point. Some folks have used an advisor portal. I think you have. And if you have a quick case you have to do an elderly patient, even with some rotator cuff deficiency, the Navisor portal would be one to do. If you weren't doing a reverse, a nail could work in that patient. So with multi-part fractures, the cuff is usually intact to the fragments, getting those ideally reduced with an open superior rotator cuff approach, because it's basically a complex rotator cuff tear with pieces of bone attached to it. Although the bone is where it tears, basically. The bone's fractured, the cuff's usually intact to the pieces, and usually there's some kind of implosion aspect of the humeral head, either in varus or valgus, lifting that head right, still going medial through the head to stabilize it, and then targeting the tuberosities through an open superior approach, which is a lost art. That's what I always did in fellowship with Tom Norris 23 years ago when I was in fellowship, and that's the one time I get to do that exposure for multi-part fractures. And it's a really great way to get those GT pieces that are in the back without disturbing your reduction.
Yeah, and then how do you manage them? So give the fellows listening a technical tip that maybe
Sure.
haven't seen as much. How are you optimizing the tuberosities before you put in the screws into the nail? How are you getting it perfectly reduced and managing them? You know, with the plate, you bring the sutures through the plate and tying them together.
Right.
How are you doing that with the nail?
Right. So first key is having a stable distal fragment. Just typical AAO technique is having the shaft in a neutral position with the forearm in neutral position. So there's no rotation of the shaft, slight extension, keeping the arm in a stable position, not moving it around. So you can just mess with the proximal pieces. So then using usually a head lift maneuver, it can be more percutaneous or open to lift the head out of varus or valgus. Having a suture in the cuff's really helpful, Eric, to pull on the tuberosities, either the lesser, greater, or both. And then one technique for a 4-part fracture is to do a quick cerclage suture to get the GT and the LT together once you lift the head. Because the head's imploded, it pushes the tuberosities out by definition. The head is the key to reduction of the tuberosities. And so that's why I think of it is reduce the head, then you can get the tuberosities anatomic. And the key is that greater tuberosity particularly, because if that heals, nothing else heals. You still get a good reverse if you need to revise that. But in any case, lift the head, tuberosities together, 1 or 2 transosseous sutures, and then can place the nail, usually with 1 or 2 small 4.5 or slightly larger K-wires in the posterior aspect of the greater tuberosity to the head to keep the head from moving.
We have a
All right,
question.
one last question from the panel. Clifton, do you want to?
Yeah, sure. This is from Ivan. Ivan, thank you for being on every one of these webinars, first of all. But well, maybe we'll just go down the line. We'll start with Jenny, then Eric, then Hots. What is your position for nailing, beach chair or supine, sloppy lateral, and where is your floor coming from? This is a great question because setup is one of the most important things for nailing. Jenny, you want to start?
Oh, sure. I guess the few times I've done it supine on a reverse sort of vascular or radiolucent table. And then I actually cant the bed up a little bit, so a little bit reverse Trendelenburg, just because it's a little bit easier for imaging. And then I have the C-arm coming from the opposite side of the table, so I can roll back to get a gray sheet and then roll over to get a scalp wide view.
Yeah, I mean, I'm similar. I plate and nail beach. Sorry, I guess I plate and nail beach chair, so it's the same for both. And I always floral from the opposite side of the bed, so it's out of my way, and I can get a perfect AP view. And I'll do the same thing where I'll tip over and to get sort of a pseudo axillary view.
The T-Max or what kind of table, Eric? One with a
T-Max, T-Max.
yeah, where the shoulder comes out. That's the key.
Yeah, yeah.
So I'll use the same T-Max table, especially for more complex fractures where I might switch to reverse. So slight beach chair, head elevated 30 to 40 degrees, 45 maybe max. And then that's ideal for a superior approach as well. For a 2-part, I think you can do it either way. And a T-Max like that, X-ray from the opposite side, agree with Jenny and Eric, that's better. But for a 2-part fracture, you can also use a Jackson flat top or what Jenny was discussing, just any kind of radiolucent flat table, turn the body up 30 degrees. And that's really ideal for getting a true AP and a scapular Y. That's a little bit quicker actually for positioning. So if you've got a straight 2-part, don't have a lot of, and you don't want to mess with that metal post in the bed, which sometimes gets in the way of the scap Y, then a Jackson flat top beanbag getting the patient up 30 degrees makes it really simple.
Awesome. All right, Clifton, you want to go to the next one?
Yeah, absolutely. And one thing I want to say about that data, like all systematic reviews, you have to look at it carefully. Like Hots was saying, there was downtrending complications per year with the advancement of nails. So the data was a little skewed to be higher complication rates early because of how poor the implants were. But anyway, okay, let's move
Just
on.
one quick question. What's your preferred position? You're an expert in this as well. What are your two-part fracture, multi-part fracture? Do you change your approach and how you position the patient?
Yeah, it's just a big bump under the arm. I like to do a Jackson flat. I bump it up 30 degrees. I get preoperative X-rays, and it's just a Grashi, and then you could see over the top and just internally rotate the arm and get real nice, quick X-rays in two planes. And then for me, like the most important thing is just the starting point. And if you don't have like those perfect X-rays, you're going to miss your starting point. If you go too lateral with most nails, you're going to kick it into varus. And I think that's how most of my failures have been, with the error in the starting point that either fractured the tuberosity or led to varus malreductions.
It's a great point.
Awesome. So next study is looking at lateral wall integrity of the greater tuberosity for the importance of stability of osteoporosis, proximal humerus fractures after plate fixation. And this study was out of Korea. This study looked at surgical fixation of osteoporosis fractures, primarily focusing on the medial calcar support. And they utilized a specific model for two-part surgical neck fractures of osteoporosis proximal humeruses to investigate how severe a combination of the greater tuberosity lateral wall affects biomechanics stability after plate fixation. They looked at 10 matched pairs of cadaveric humeri assessing surgical neck fractures alone or surgical neck fractures with greater tuberosity lateral wall comminution. They removed 5 millimeters of the lateral wall of the greater tuberosity to simulate severe comminution of the lateral wall. And then they looked at axial compression, stiffness, torsional stiffness, varus bending, and single load to failure and varus bending were measured for all constructs. So they found that the lateral wall group showed a significant decrease in all measures, including torsional stiffness, axial compression stiffness, and varus bending. And in addition, the mean single load to failure or varus bending of the lateral group was 60% lower than the surgical neck group. So they conclude that severe comminution of the greater tuberosity lateral wall simply compromises the biomechanics stability of osteoporosis, common humeral neck fracture. So Jenny T, you commented a little bit about your plate fixation, which were awesome points. When you see lateral wall comminution, what does a study change how you change your technique at all?
I don't think so, because I've had scenarios where, the tuberosity essentially is a shell, which I guess you could equate to being a lateral wall deficiency. And so in those, I typically err on the side of putting in structural graft, maybe not necessarily to support the calcar, but actually just give lateral support. And if anything, also increase my fixation points of my locking screws, even though it is, going through a locking plate. Figured if it can go through bone before it hits the head as opposed to air, that would add more. So to me, this study is doesn't really wouldn't affect my choice. Now, I mean, they looked at osteoporotic bones. So you can make the argument that someone who's got a known diagnosis of osteoporosis maybe shouldn't be fixing those. But I think that's another question or debate.
Yeah, I mean, this paper is interesting because I'm not sure how clinically relevant this model really is. It's, these fracture models I think are interesting, but the way they have to sort of generate a simulated comminution, they're just removing this big chunk of bone, which is not really what you see clinically. And then they also have no suture fixation in the plate either. So, I mean, I agree. I'm not sure this actually would change my technique at all because the model's sort of not as clinically relevant as what we actually see when we're doing these cases.
So Eric, in these young patients with maybe a better bone, but let's say they have metaphyseal deficiency, and so they maybe they have okay tuberosities, but they're clearly have some comminution in the metaphysis. How are you making up for that? Are you, as Jenny mentioned, are you doing a graft? Are you using that a different way with the plate? What's your thoughts on that kind
I
of change?
like using the graft as well. I think, if you use like a fibular strut, for example, whatever graft you choose, I think it's a great technique to get stability when you have this sort of metaphyseal bone loss because you can put it in and stabilize it and then sort of impact the humeral head onto it. So you get this sort of skewering impaction effect where you get stability from that strut or whatever structural graft you like to use. So if I've got bone loss, I think it's a great additional technique both for fixation and reduction. And then, like Jenny was saying, it's just another layer of structural bone when you're putting your locking screws in that gives you added fixation. So I find that I there was a period where it seems like people want to put fibular struts in everything, but like I keep it to those kind of situations because if you ever have to go in and revise those, they can be challenging. So it's really those narrow cases where you've got that kind of metaphyseal bone loss you're talking about.
Eric,
It's
can
the
you comment on that?
biologic nail approach, right, Eric?
There
Biologic
you
nail
go.
to the plate.
There you go. You just skewer it.
Eric, can you talk about your experience with revising fibula struts? Because I never use them because I just hate revising them so much. I know everyone talks about, hey, it's not a big deal, but like I find them to be really hard. How do you do it? What's your technique?
I think the challenge is, I mean, if they heal in really well, you sort of lose your intramedullary canal, and then you just have to be really careful in those cases. If you're revising someone to an arthroplasty, that you identify your canal appropriately and don't cause an iatrogenic perforation. So I mean, those are the cases I'll be very careful with fluoro. You can, depending on it just depends on how complicated it is. If you're using fluoro, you've got your pre-op CT, you can use those cues to take a burr and open up the canal. If it gets really complicated, then that's when, I think using techniques like people will talk about with potentially a cannulated reamer where you can get a cannulated guide pin through the healed graft distally and then ream over it to know that you're safely opening the canal up. But yeah, those can be very challenging cases. I think that's why you've seen this sort of downtick in using the strut like all the time because people talk about that a lot.
Yeah, those struts are impossible. I agree. Unfortunately, my trauma center does a lot of those, and those are really hard cases. Sort of part of the reason why I chose this article is for that kind of metaphyseal combination lateral wall. Part of it was the tuberosity. So going to tuberosities, obviously, and then we'll get to that in the next article. Tuberosity, non-union or malunion, is a really, really difficult challenge to treat. How are y'all, if you have an isolated tuberosity fracture that's very displaced? Why don't if y'all, we'll go through each one of y'all and see how you prefer to manage those, both approach wise and then fixation construct. So Hats, you want us to start us off?
Sure, great question, Eric. Thank you. So most of the GT fractures I see have smaller fragments. So they're not really super fixable. They're more fragmented, smaller pieces. Typically fix those arthroscopically with basically bony arthroscopic cuff repair technique, double row, medial anchors, and then lateral ankles, a little more distal than we usually put them for the smaller pieces. For a bigger piece, which I haven't seen one in practice for a little while, either percutaneous screws or open approach, superior approach with screws that go to the neck, or some of the proximal plates that have been made that are really elegant.
Hot on those arthroscopic approaches. I agree. It's a nice approach, but some of the struggle I've had on those are the getting a good suture anchor fixation because of the actual fracture itself. Can you talk about maybe how do you optimize that? How do you change that compared to your normal just standard double row rotator cuff?
Yeah, absolutely. So, as you pointed out, the usual dead man's angle doesn't work because there's no bone there. So, usually angle a little more underneath the articular surface
Yeah.
to get those anchors in. Just testing with the awl first and seeing if there's a good tunnel for the bone. So, usually some kind of swivel lock corkscrew type anchor with augmented fixation works pretty well for that, in my experience. And the distal ones are a little harder though. And sometimes I think you have to go a little sideways. You have to cross sometimes. So, take the posterior to the anterior cortex, a little more distal, and anterior posterior to cross so that it's not straight distal and don't have to go way down the humeral neck and even endanger the axillary nerve because you're dissecting too far out. Although I know you expose that arthroscopically probably on those.
Crazy.
All right, Eric, what's your approach? Isolated tuberosity, very displaced. What's your approach? What's your fixation contract?
It's funny, greater tuberosities, I am just as invasive as regular proximal humerus fracture. For some of the things that have just been mentioned, early on in practice, I remember reading about techniques like you can put a couple screws in it without a plate, or do suture fixation only, or even arthroscopic. And I've had cases trying to do all those things where it just pulls out because it's this comminuted piece. So I've evolved to plating those just like any other fracture. And I like the technique. I actually learned it from Charlie Getz in fellowship. It's proximal humeral locking plate, delta pec, and you put the plate down, and then your plate are your suture fixation anchor point for your fracture. So you can just anchor all of your greater tuberosity sutures into the peripheral suture holes of your plate. And I've found that to be the most stable way to always reattach the greater tuberosity, when it's comminuted, and not have to worry about whether I'm going to try to get bone tunnels through bone that's not great, or put anchors through bone that's not great. So I always use a plate, and there'll be less screws in that scenario. So if the fragment's really comminuted, it may only have sutures in the fracture, and I'm passing the sutures through the plate. So there's, I don't necessarily put a bunch of proximal screws in, and then I'll put a couple shaft screws in. So that's always been my technique.
Use a regular proximal plate, Eric,
Yeah,
standard, or
just a
use a
standard
specialized?
proximal humeral plate. If the piece is big enough, you can maybe get a couple screws in it. But if it's not, I'm just using the plate as the anchor point for my sutures.
Delta Pec or Superior Approach?
Yeah, Delta Pack. I've always done Delta Pack, and I'm just comfortable with being able to grab that fragment with tagging sutures, and if it's posterior, bringing it back around. And so that's kind of become my standard way. It's definitely more invasive than doing sort of an arthroscopic technique, but I just feel like it gives me a stable anchor point.
Does anyone use a deltoid split for an isolated greater tuberosity?
Perfect. Jenny, talk to us about isolated greater tuberosity fractures.
Yeah, so that isolated greater tuberosities are probably the only time I would use a deltoid split. My bias is mostly due to it for a delto pec. So I use a combination. Instead of using a pre-contoured proximal humerus plate, I actually use a T-shaped mini frag plate, either 2.4 or 2.7. The reason why I like the T shape is that I'm able to sort of contour the top part to really kind of hug the front and the back to really kind of capture the tuberosities. And so then I'll put, my buttress screw, screw distal in the shaft, and then screws through the T portion of the plate, usually 2 to 3. And then in addition to that, I'll back it up with sutures that either independent sutures through the bone tendon junction of the cuff and tie that over the plate. Other things I've also done is actually anchored the sutures through like a lateral row style anchor as well, distal and around. But that's worked pretty well for me. And then I feel pretty comfortable that it's captured, and I let them, I rehab them a little bit faster. But yeah, but it's one question I actually maybe wanted to ask. I think when I was in residency, tuberosity resorption in isolated greater tuberosity was like a big thing. I feel like we don't really talk about it anymore. I don't know if maybe is that because our techniques have evolved, or maybe we just stopped talking about it because we haven't figured out what causes it. But maybe to some of the other panelists, any thoughts? Do you still see tuberosity resorption in your practice?
I think to some extent, yes. In most cases like this, they just compress and um, reabsorb, or they remodel. But a lot of times it doesn't have a clinical consequence. What do you think, Jen? I mean, have you seen that happen and have the patient get cuff weakness?
I haven't, and maybe I don't follow them long enough, or maybe they just don't come back. But I haven't seen a significant amount of tuberosity resorption. So I don't know if it's the technique or overtensioning or not overtensioning. But yeah, just curious.
I don't think I've seen a lot as well either.
This is an awesome question again from Ivan, and I don't know if anyone's familiar with this, but our oncology partners use this thing called the Illuminos. So have you ever seen this? It's a catheter that goes into the fracture or whatever, and it's a monomer that gets like kind of essentially solidified by light. You can actually drill through it. Is there any utility for that instead of a fibular strut? And if you don't use it, like, have you used it? Have you revised it? And if you haven't, maybe we could conceptualize if that'd be worthwhile doing.
I mean, my tumor partners definitely use it. I've actually never used it.
Not either. I think my only concern is, although the reps say, oh, if you need to take it out, or if you need to do a reverse, you could just drill right through it. But to me, I think the unfamiliarity with the potential disasters that can happen, if it gets infected, for instance, I think to me has just been my barrier in using it.
I haven't used it either. But in the hospital that I work at has not wanted to use it because they quote have a high complication, i.e., death rate over the years. But they sometimes don't realize it's in a lot of patients with cancer. That it's just palliative care. So
Awesome. All right, let's move on to the next one. So the next one's going to be complication in the reverse shoulder arthroplasty for proximal humerus non-union. So this is a retrospective study out of the Mayo Group for proximal humerus non-unions done, or reverses done for proximal humerus non-unions. 50 total reverses with a mean follow-up of 49 months, minimum follow-up of 11 months. Total complication rate was pretty significant, especially given the group it's coming out of. So a 34% total complication rate, a 20% reoperation rate. 12% of those complications were dislocations and 10% were humeral loosening. So really high, much higher than you see in just a regular standard reverse on the humeral side, especially. When you looked at these specific complications or dislocations, humeral loosening, there was the prior surgery, prosthesis type, and tuberosity management did not seem to impact the overall dislocation rates. And interesting enough, when you're looking at the SRSs or the APCs, those trying to replace some of the missing bone with either metal or cadaveric bone, it slightly improved the dislocations, but it wasn't significant. That being said, in the APC group, there was no humeral loosening, so maybe that was moving in the right direction, but it's really hard to say, especially in this, given the overall complications. Survivorship free of reoperation was 73% at 2 years, and it was worse in younger patients, those with diabetes, and then those that had prior ORAF previously, as you can imagine, a bit difficult. So really awesome study. As usual, this is something just showing the difficulty managing these complex patients when you have the greater thoracic non-unions. Shows the high complication rate, shows really on the humeral side and the joint stability side is really where you have difficulty. So humeral loosening, dislocations, and showing that with a variety of different types of techniques in these patients, it didn't seem to have major differences, and it's something that I think we still are learning about how to best manage these. Naturally, those that had non-op versus ORF seem to be a bit more difficult, as you can imagine, but overall, great foundational piece, I think. So, all right, Jenny, this is coming out of your institution. Talk to us when you're seeing a patient that has a non-union. How are you a greater thoracic non-union? How are you thinking about this patient? How are you managing it? Are you only doing reverses? And when you're doing reverses, maybe talk about how you're approaching that.
I think it depends on the fracture pattern, right? So if it's a two-part, like a real two-part surgical neck non-union, for those, regardless of age, my bias again, I think, is to fix and graft. If you're getting into the 3-4-part non-unions, I actually today just did a 4-part non-union for fracture for reverse, and it was horrible. But yeah, I think those are really challenging. I find that the shoulders are tighter. You'd have to like osteotomize, the tuberosities if they are malunited. But yeah, I mean, I also think that because the shoulders are tighter, even though most of these patients don't have glenodeformity, I certainly have had times where my glenosphere or my pin from my glenoid is way off. So again, I'm very comfortable using fluoro, so my bias for these is to use fluoro too. Yeah, but certainly challenging, and I think makes me want to intervene earlier for some of these patients.
Yeah, for sure. Eric, are you always trying to make up for this? If you have a non-union, is there a circumstance where you're trying to osteomize and then bring it back and maybe around a fracture? Is there other circumstances where you're making up for it with maybe metal or allograft? Like, how are you managing the tuberosities in these reverses, in these non-unions?
Yeah, I mean, these are very, very challenging cases. Typically these non-unions will have these sort of cavitary, because of the non-union, sclerotic non-union sites where there's very little bone left on the head fragments and the tuberosity fragments. And I typically will repair the tuberosities rather than go to an APC or a proximal humeral replacement, but you can see the consequence in this article. You're reattaching tuberosity fragments that are very thin and potentially sclerotic and have poor healing potential. And that's the challenging part of these cases. So even if you do a good job with tuberosity fixation and tuberosity repair around a fracture-specific reverse stem, you can have poor healing of your tuberosities compared to a primary case. And I think that's what creates these scenarios of instability. If you have resorption, you're going to get proximal humeral bone loss and eventual humeral component loosening. So it's this cascade of problems you see in these fractures. And I don't think we routinely consider APCs or proximal humeral replacements in these. You can see in the study it was only a handful of the cases, but it is something I think you could consider thinking about more because of the challenge you have with tuberosity healing in these scenarios. Some of these can be different where if it's an early non-union, they define it as 90 days. So maybe if it's an early non-union, you're going to have better bone quality. But if it's a non-union that's a year old, I mean, that's a challenging case.
Yeah, well, great. Hots, when you're revising somebody that was non-operatively treated with this non-union versus somebody who had a prior surgery but unfortunately pulled off maybe a plate, maybe a nail, maybe talk to us about how you approach those differently, if you do approach them differently when you're revising them to reverse, and maybe how do you optimize each here and there?
I think it's a great question, Eric. Thank you. With an operatively treated fracture, I typically hold antibiotics and get cultures because I think low-grade infection, sometimes high-grade that's compartmentalized or held inside, kind of sequestered inside, will lead to that. So obviously, a different outcomes with that and causing septic loosening than with a low-grade fashion. For someone who has not had surgery, I agree with Dr. Tangti Putana. I think I said it right. I tried with fixing those if we can, and I will plate some of those as well. I think those are good for a bone peg, bone graft. That's where the fibular strut came around. They took Gilles Walsh's technique and applied that to fresh fractures. I think malunes are really interesting too, Eric, in that it's really easy to detach the whole cuff from the bone if you're not careful. Really easy. So one trick I've found, I think a lot of those are apex anteriorly healed, internally rotating the arm, really going to the subdeltoid space, getting a good retraction there, and osteotomizing the GT off the shaft can preserve a lot of bone there so that you get better fixation and not come out and say, oh boy, where'd my cuff go? Because that can happen pretty easily in a malunion, which are often hard to dislocate even. So reducing a little bit of the supraspinatus, but really internally rotating and osteotomizing that whole GT off the shaft. I think that can really help minimize complications and get a better result with your reverse. With a fracture stem, I like the fracture stems for all the above scenarios. I think some of these fracture stems that have a little bit of shape proximally in the canal can decrease that risk of loosening and anticipate. It would have been nice to see some figures and some pictures of some of the worst case and best case scenarios from here. But there are some old cases here and anticipate some of those cases had cemented cylindrical stems. And when we looked at the original Grammats with Pascal, when I worked with him as a fellow, humeral loosening was a problem. And it was because they were cylindrical stems. So having some texture, some shape proximally to get some grab in the proximal metaphysis or metadiaphysis, I think is really helpful. What do you
So
think,
then
Eric?
are you cementing? Are you cementing? Are you in black and tan on these non-unions? Are you doing a distal fit uncemented?
Yeah, distal uncemented for the cases when there's no real structure proximally to get some metaphyseal fit. But with a lot of these cases, I think if you have a fracture stem with some proximal shape, you can get a lot of press fit there. So I might just put a blob of cement along the shaft, and that's doughy, and get some provisional fixation. Some components have screws you can use, but getting a little bit of cement augmentation, getting that macro structure to engage proximally with bone, a little bit of black and tan variation technique can help in those cases. What do you do, Eric? I want to hear your opinion. You're a great moderator. I'd love to hear your technique.
Other Eric.
Yeah, well, yours too, Ricchetty, but I want to hear Waggy.
But I mean, these are cases I will try to not cement acute proximal humerus fracture reverses, but these you very often have to cement because the bone quality is just a lot less good, and so you need rotational stability. But I agree, the black and tan technique's a nice way to try to get better bone healing of your tuberosities to the implant. Sorry, go ahead. Sorry, Wagner.
No, I mean,
Other
these are hard. I would
Both
agree.
Erics.
I think I agree with you. I tend to be a little bit more aggressive, I think, at doing APCs on these because I do find unsatisfying reductions on the tuberosities. And unless I have a really big piece that I feel I can get back and do a nice, almost turn it into an acute fracture where, like you said, the osteomyes, you have to osteomyze medially, really mobilize it, bring it back. Then outside of that, I tend to be a bit more aggressive at doing APCs, but that's potentially a bias of just seeing a couple. I had a bad early complication one where it, just like this article talked about, where I thought I got it back, it didn't get back. And then as Eric said, like 2 years later, the stem was starting to loosen. And then I had sort of like a catastrophic failure with like a fracture distally and ended up turning into like a huge APC at that point. So I think, you're always scarred by your complications, but I think has made me shade to doing more APCs for these.
Cemented APC or a press
yeah,
fit APC?
Eric, you can't get, you're not getting out of this. We want to hear about APCs.
No.
Wait,
Yeah,
wait,
cemented or press fit APC? I'm curious.
With or
Plate-
without
I
cuff.
don't I don't only submit to APCs because I don't think allograft you don't get any ingrowth in allograft. I do a locking compression plate to sort of help both with the fixation and maybe help with some of the resorption that you've seen in some of the other constructs. But we'll see with the test of time. The great thing about APCs, they look really good, just like a distal tibial allograft. They look really good right when you finish. We'll see 5 years down the road if they still look as good.
I mean, and the other point, about these these chronic surgical neck non-unions, they're typically in varus, and they've been like that for a year or longer. So when you're trying to bring your greater tuberosity back to reverse implant, the superior cuff can be so contracted that you often have to release some amount of the superior cuff as well. So now you're dealing with a thin tuberosity fragment that you've also had to take a bunch of the soft tissue off of it as well. So that it's just another point to how these are just more challenging cases to get good tuberosity healing.
Riccati, how important is the lesser tuberosity to you in these cases?
I mean, I try to keep bone support around my stem because, to Eric's point, if you get resorption and you have a bunch of unsupported metal proximally, you're going to eventually get stem loosening. So I try to reattach both and have as much, hopefully, proximal bone healing to the stem as I can get if I'm trying to, keep the native bone.
I agree. Any role for bone graft substitutes or using the original head cancellous bone to help? I guess we talked about that a little bit with black and tan, but is there any role for substitutes in any of your minds, Chris, Clifto, to augment fixation?
bone graft substitutes for this. No, I don't see there's any role for that. I've used some of the like Permatage montage, like no affiliation with them, and the Permatage is nice because you can actually like structurally it'll lead to support, it won't resorb. It's been okay, and then montage resorbs and hasn't done that great, and all the bone graft substitutes are that way. So, like Eric said, I don't think so. There's a big role for biologics with these fractures.
That's tough.
And Eric Wagner, just to clarify for the audience, your allografts have cuff attached.
They do, yeah.
So you're
So
repairing cuff to cuff or
they are cuff to
allograft cuff
cuff. So
to
I'm
native
repairing,
cuff.
yeah. So I'm repairing cuff to cuff. So subscap and the what's attached to the greater to actual cuff on the allograft. So it's the allograft that have cuff on. That's why I do the APC instead of an SRS or a metal. Is I like the ability to repair cuff to cuff. So yeah.
How challenging is it to get that graft?
How challenging the graft? It's actually
Yeah.
it's through MTF. We have it consistently. Maybe it's living in the ivory tower of Emory. I'm not sure, but like I've never. That's not hard. Now elbows can be sometimes challenging, especially female elbows. They're small enough. So if you're doing elbow APC, I found that challenging. But for humeruses, we have like an endless supply. It seems like. So
Jenny, have you guys had problems?
No, we haven't, but I realized that Mayo is in its own little bubble, which is why I asked, because, I think in my prior job, depending on resources, it takes a lot of planning and requesting. And so I wasn't sure what the turnaround time is outside of Rochester.
I've had difficulty with
Because
it.
I use cuff attachment APC as well, and we get it easily, but I've heard a lot of colleagues say it's difficult depending on where you're at.
Yeah, I've struggled with it. You can get APCs pretty readily if you don't need a cuff, but if you really want like cuff attachments, especially with the different sizes, it can be quite challenging if you're not at one of the pillars.
There are for those listening, there's the MDF is the main one, and that's where I think a lot of us get it from. There are commercial ones as well. Some companies even have started being partnering with some of them. So there are other opportunities if you can't get it, if there's a delay through MDF. Around COVID, we had a kind of delay. That's how I found that out. But anyways, why don't we go into the last one, Clifton?
All right, sounds good. So this is going to be like a little bit more of a challenging one to present. So I think we're just going to go slowly. It's the Delphi consensus statement from ASES. And for those of you who don't know, every year the NEAR Society comes together and they come up with a consensus statement on challenging topics. And a couple of years ago, it was on proximal humerus fractures. So the way these work is they essentially give you a vignette, and then through the vignette, you say, would you fix it? Would you not fix it? How you would do it, or whatever the situation may be, whether it's labrums, slaps, whatever. So this was on proximal humerus fractures. There was 86 participants in this, and they looked at 3 surveys of vignettes with 2, 3, and 4-part fractures in 2 scenarios. One was a 55-year-old and one without medical comorbidities, healthy, and one was a 75-year-old with significant medical comorbidities. And then they looked at pre-op and post-op management. So I'm just going to go over the consensus, and maybe we go one by one and see what people feel about each consensus statement. But CT scans prior to proximal humerus fractures. This was a consensus. Maybe we just go down the panel. Does everyone get a CT scan for proximal humerus fractures?
I don't.
If I think it's operative, I do.
Thoughts?
Not for 2-part fractures typically, but for more complex fractures, they usually come in with one, but I'll get those just to understand the fracture pattern better.
And then age was a significant determinant. Is there an age cutoff when you're going to consider operative versus non-operative? Again, if you want to use their parameters, there's a 55-year-old and 75-year-old. Maybe we'll go with HOTS for this one.
No, I don't think so. I think it's physiologic age. If someone's on death's door, obviously you don't do surgery in patients. But I look at bony contact. So if someone's unhealthy, there's good bony contact, the head's facing the glenoid, I'm a little more apt to try conservative treatment. It's not age-based.
Okay, awesome. We'll go with Eric on the next one. Bone quality. They said bone quality was a significant determinant. What do you use to determine bone quality if you're going to fix it or not fix it?
I think that, if I'm trying to make a decision pre-surgery, so my imaging, my x-rays, or if I get a CT, it's based on level of comminution, cortices, signs of, osteoporosis. But then intra-op, if I think I'm taking someone to surgery, I generally go to surgery thinking I'm going to give it a shot at RIF, but if not, put a reverse in. And so intraoperatively, I'm looking at the quality of bone as well. If I've got some of the things we talked about earlier in terms of severity of comminution, not enough bone on the head segment, loss of medial calcar soft tissue, those kind of things are going to push me for reverse instead of RAF.
All right, awesome. We're almost done with consensus here, Jane. The next one for you is patient-specific factors. Consensus was reached for 2 parts, 3 parts, 4 parts, 4-part dislocation, essentially in the 55-year-old. So it looked like anytime there was essentially a younger patient with a proximal humerus fracture, they're going to fix it. The only consensus for the older patient was 4-part with fracture dislocations. Maybe comment briefly on age as far as, do you fix all of them for younger patients around 55? And do you only do 4 parts with fracture dislocations for older patients?
Yeah, I mean, I think I agree with the comment that age is just a number, right? I go based off the physiologic age, and I think the challenge with these vignettes is you don't actually meet the patient. I can see why there was consensus for the 75-year-old fracture dislocation, right? No one's going to leave a humeral head dislocated. But some of the other images that were shown, in the vignette, like I would probably treat the 3-part and the 4 parts in the 75-year-olds. Just because of, risk of non-union, pain, malunion, all that stuff. Again, if they're on death's door, they have high risk for complications, certainly, then it becomes a conversation of like, we're just going to accept a mediocre outcome with non-operative treatment. But if they're remotely functional and are independent, then I'm thinking about surgery for them, because I feel like I've seen a lot of patients suffer in those like 6 to 8 weeks while you're non-opping them. And, for someone who's 75 who might not have that much longer to live, you can think about potential, short-term quality improvement of life as opposed to, I don't know.
And last
philosophical debate.
question. Awesome. Last question before I turn over Eric to continue to moderate. Maybe Hots, no consensus on rehab. Do you have a rehab protocol? When do you start active motion for these patients? For
Yeah,
OIS?
for fractures I fix, I check the intraoperative stability. I start passive motion right away, and I keep it within that range. So if someone gets to 140 and I feel like, whoa, that's stable, I'll let them go up to 100, 120 degrees of passive motion because I don't think it's going to put a lot of tension on that. For patients I'm treating non-op, elbow, wrist, fingers to start with, see them every week. And at 3 weeks, I typically want to start some passive motion at that point, but I follow them pretty close to see how stiff they're getting.
Beautiful.
I'd love everybody to look at page 5 because I think this is the hard part of these studies. Page 5, V1, two-part varus, young, healthy. By Neer's criteria, is that a two-part fracture in everybody's mind? I just want to take a quick poll. Is that okay, Eric?
Yeah,
What do you
please go ahead.
Page
Love it.
5,
Jenny.
V1, two-part varus, young, healthy. Forget the young, healthy. Just look at the X-ray. Is that a two-part fracture?
Two-part, well, I would call it a two-part, but by Neer's, editor definition, imposed definitions, it's not, right? It's not more than a
Right.
centimeter and it's not 45 degrees angulated. So
Eric, what do you think?
I mean,
Is your
yeah,
master of literature?
no, I agree. It's like my judgment on displacement is not exactly the same as near criteria. So I agree it doesn't meet the near criteria, but I would still consider it a true fracture.
I agree
A true-
totally. Herbert Resch has said at one point 30 degrees should be but we don't really have consensus on that. I think that would be a great direction for us to go at some point. What do you think, Eric Wagner?
Yeah, I mean that's a great point. Like actually better defining that really poorly defined what it means to be displaced, what it means the angulation, what's tolerated, the overlap, all that stuff is would be actually a really interesting consensus statement. Or as Clifton has been leading some of these studies that do Delphi or modified Delphi criteria. That'd be a really interesting one to do. So Clifton, maybe you should do that after you finish the cuff one. But yeah, I mean, I think the interesting part, well, there's a couple interesting parts of this, but one is if you look at these quote unquote two parts, actually, so I'm going to throw it back at y'all. So that this is what I was going to end it with is, two-part fracture I think is an interesting one because my co-fellow Jarrett Woodmass told me that every two-part fracture heals just fine, and that you just need to put them all in cuff and collars. And in Canada, they all get back to hockey, and there's no problem. I haven't really seen that. I have to admit, I that was my initial bias because he sort of made that comment, and I thought that was the case. Maybe Americans are just really poorly tolerant of cuff and collars, and Canadians aren't. But what are your first off? Well, would y'all treat those two parts surgically or not surgically? And then secondly, when are you treating these two parts circle next surgically? So maybe we'll go down the panel as the last question. So Hots, you want to take that?
Oh, sorry. Yeah, I think looking even at that picture, I try to think, what would I want? And try to extrapolate that to younger and older patients. I think V1, and if I had that fracture, I would want that fixed. So usually I do a percutaneous nail in a fracture like that. And whether they're 35, 55, or 75. Now, they get to 75 and 85, I tell them, listen, you're probably going to lose some elevation, 30 to 40 degrees of elevation at least with that. Do you care? And I try to demonstrate that with them. And if they say, well, I don't really care about that, maybe it'll give me an excuse not to do chores and get things from the shelves, then I say, okay, well, let's see how non-op does. But if someone wants to have, quote, as close to full function as possible, I think some of those in-between fractures should be fixed.
Eric, what are your thoughts on those two top ones, young, healthy, those two parts, and when are you fixing two parts?
I mean, I would agree with what Armin said. I mean, you can see, and it's what patients' functional expectations are a part of it, because you can see varus malunions that are very symptomatic in someone that's young and active for exactly what he said. They're limited in their forward elevation because of tuberosity impingement, and they're not happy. But a 75-year-old low demand patient may not care about that. But if someone's active, wants to maximize their function, though, that fracture pattern can do poorly with malunion. So I would fix that in someone who's young and active.
Jenny, do you want to come at this, given you have probably the most unique experience with both the trauma world and the shoulder and elbow world, these two parts, which, once again, Cananda and in Jared's defense, most of my colleagues at Grady also treat these without surgery. Grady's our big trauma center at Emory. That being said, I have the bias where I would tend to be a little bit more aggressive with some of these ones, especially in younger patients. So maybe to help us resolve this discrepancy that we're seeing, or how are you approaching this?
Yeah, I mean, I think it's interesting that, these x-rays, it's only one plane of deformity, right? I mean, so usually for these patients, if I am following them, I get a Gracie view and a scap Y view. And I think what people get fooled about is, it might look okay on the AP view, but if you look at a scap Y view, they've got significant apex anterior, or, more than 50% translation of the shaft. So you talk about non-union, and, I agree that not all of these heal. And so that shaft head displacement, I think, really would trigger me one way or the other. But I also agree, usually these are my longest visits. I spend a lot of time talking to patients, and, I tell them like, hey, I can certainly make your bone perfect. And then if, then we can rehab you faster, then we know that we've eliminated a bony deformity as a potential cause for your stiffness. And so if you phrase it that way, most patients are like, oh yeah, sure, that sounds great. Eliminates any sort of doubt. But yeah, but I think, always making sure that you evaluate deformity in two planes.
Jen, how much apex anterior angulation do you think is okay? Because I totally agree with you. The apex
Yeah,
anterior is a real bad actor.
I don't know. I was going to ask that question.
You
To
first.
see, yeah, because I think in the forward elevation plane, right, I don't know. I was going to guess no 45 degrees, but even that seems a lot. And I had a patient recently who I got a CT scan on, and her coronal and sagittal alignment actually looked okay, but she was incredibly retroverted, which I couldn't appreciate. I only saw it because I got a CT. So yeah, I don't know. I think the deformity and what people can tolerate is a black box that would be great if we could answer and provide guidelines for. I think there's biomechanical studies that have looked at amount of varus and contact pressure, in the subacromial space, but I don't know how clinically relevant that is for patients.
I think maybe not in that fracture discussion, Jen, but in some patients I see, just getting them in a neutral rotation sling with a wedge
Mhm.
pillow sometimes is really interesting. It looks terrible on the first views you get, and especially from an outside institution, get a good Gracie, neutral
Mhm.
rotation of the forearm in a sling, get the sagittal, they get the lateral view in the sling with scap Y, and then get the true AP. And sometimes it reduces pretty well, but sometimes it
Mhm.
doesn't.
Yeah.
Yeah.
Awesome. Yeah, thank you all very much. This was great. We're gonna wrap it up just we're touch over time, but thank you. This will, for those that are tuned in, this will be posted, and for those that missed it, the same place that the other ones have been posted. Steve will send that out at a later date if you want access to this. But Chris, Jenny, thank you very much. This was awesome. Y'all are great, and learned a ton. I don't know, Cliff, do you have anything you want to leave us with?
It was awesome. Learned a ton, and thank you for the awesome discussion, everyone. And thank you for everyone attending on this Tuesday night. We really appreciate it.
All right.
Thanks, Chris. Thanks, Eric.
Thank
Yeah.
you.
Good one, guys.